Good morning, everyone. So, in continuation with our previous two talks, which were based upon the fifth edition of WHO classification of hematolymphoid tumors, uh, that is WHO-HEAM5 lymphoid neoplasms, we have been talking about the mature B cell lymphoma. So today I'll try to finish whatever is written in about the mature B cell lymphoma in these articles. And I will be covering the remaining lymphomas, which are Burkitt lymphoma and KSHV, HHV8 associated lymphoid proliferation, that lymphoma and lymphoid proliferation is associated with immunodeficiency disorders, and plasma cell neoplasms. So I'll be, and also Hodgkin's lymphoma. So I'll be covering all these, whatever the changes which have been given in this article. We will be discussing that and with a brief mention of what was given in the previous classification. So we'll start with Burkitt's lymphoma. What is the most important change in Burkitt lymphoma? That is EBV matters. So similar to the fourth revised edition, definition of the Burkitt's lymphoma is unchanged. That is, it is described as aggressive mature B cell neoplasms of medium-sized cells and has a GCB, that is germinal center B phenotype, that is CD10 BCL6 positive, BCL2 negative or weak, characterized by a high Ki67 index, that is high mitotic activity more than 95%, and a classical immunoglobulin MYC juxtaposition, that is translocation 814 is characteristic, but it can be other classic. MYC is on the chromosome 8, so it can be 28 or it can be 822, depending upon which immunoglobulin is involved in the translocation. So the definition includes IG, not IGH or IgK kappa lambda. So IG or mixed juxtaposition. So the definition that remains unchanged from the HEAM4 revised edition. While what are the changes which are given in the HEAM5? So that is, they have described two subtypes based upon the EBV status, whether it is positive or negative. So previously also there were subtypes of with this Burkitt's lymphoma, which were epidemiological, like endemic, sporadic, and immunodeficiency associated. But now this EBV subtyping, it supersedes the previous epidemiological subtyping, and WHO-HEAM5 recommends that you classify Burkitt's lymphoma as EBV positive and EBV negative, because that will change the treatment decisions. So the pathogenesis of Burkitt's lymphoma can be described as mutational, which is EBV negative, and the second is virus driven, that is EBV positive. So there are some features which are common in both these origin of lymphoma, and then there are some which are specific to the EBV positive Burkitt lymphoma. So what are the features which are common in both? That is coding mutations. In our genome, there are two regions, coding regions and non-coding regions. So in the coding regions, the mutations which affects the BCR or phosphatidylinositol 3 kinase signaling pathways, apoptosis, SWI, SNF complex, and GPCR signaling. All these coding mutations, they are seen in both of these, whether it arises from the mutation or whether it arises from the EBV positive status. These mutations are there, but there are certain things which are specific to EBV positive Burkitt's lymphoma. What are those? That higher somatic hypermutations in non-coding region near transcription start site. So the incidence of somatic hypermutations is higher in the non-coding region, and while the driver mutations, they are lesser. So as the names itself suggests mutational, so the mutations will be more here. So the EBV positive will have a fewer driver mutations, particularly in the apoptotic pathways, and also this TCF3 or ID3. So TCF3 is a transcription factor, and ID3 is its negative regulator. So Burkitt's lymphoma classically have many of the cases they have mutations in these, but in cases of Burkitt's EBV positive Burkitt lymphoma, the incidence of these mutations are fewer than as compared to the mutational EBV positive, EBV negative Burkitt's lymphoma. So that those are the changes in the Burkitt's lymphoma, that is EBV positive or negative, and mutational status based upon whether it is mutational derived Burkitt's lymphoma or EBV positive Burkitt's lymphoma. So the next entity that we will discuss today is KSHV HHV8 associated B cell lymphoid proliferation and lymphomas. So the terminology is the main changes that in the terminology. So here previously they have described it as only HHV8 associated, while now they are using the term as KS stands for Kaposi sarcoma, KSHV/HHV8. So why they have done this? It is done to accommodate the common practices of both hematopathologists and the virologists. So what are the entities, what are the changes in the entities in HEAM5 as compared to the HEAM4R? So primary effusion lymphoma, previously it was included in the large B-cell lymphoma family described in the chapter of DLBCL. Now it is included under the family of these KSHV, HHV8 associated lymphomas. HHV8 are associated, like I said, the only name it changed from HHV8 to KSHV, HHV8. And similar to that, this HHV8 positive DLBCL, NOS is dropped and it is KSHV/HHV8 positive DLBCL. Then this HHV8 positive germinotropic lymphoproliferative disorders, it's remained the same except the KSHV is added. So yes, this multicentric Castleman disease, previously it was defined under the heading of these HHV8 associated lymphoproliferative disorders, but now it is renamed as Kaposi sarcoma herpes virus, KSHV/HHV8 associated multicentric Castleman disease. And we have discussed about this previously, that it has been now reclassified under the tumor-like lesions with B-cell predominance. So it's not a neoplastic entity, it's a benign mimicker of the lymphoman. So that's why now it has been classified as tumor-like lesions with B-cell predominance. Okay, so then HHV8 associated LPDs now become KSHV, HHV8 associated LPD and lymphomas. So these are the entities which are now in WHO-HEAM5. So the entities still remain 4 only. So the primary effusion lymphoma is in, and then this KSHV8 associated multicentric Castleman disease is out and now reclassified as tumor-like lesions with B-cell predominance. So these are primary effusion lymphoma or extracavitary primary effusion lymphoma and KSHV, HHV8 associated DLBCL. These are characteristically seen in HIV positive patients. And although they can also be seen in other immunodeficiency settings, but classically they have been described in HIV positive patients. While this KSHV, HHV8 associated germinotropic lymphoproliferative disorders, they are more prevalent in elderly without any overt immunodeficiency, although they are reported in HIV positive individuals also. Like in this, they are commonly seen in HIV patients and but can also be seen in other immunodeficiency. This entity, this is more commonly seen in the elderly without overt immunodeficiency, but also reported in HIV positive individuals. So this category itself is a little bit of confusing in the classification, confusing part of the classification. I'll come to it when I describe the lymphoma and lymphoid proliferation associated with immunodeficiency. But just to briefly cover this, diagnosis of prototypical cases of various entities. So whichever the prototypical cases are there, the diagnosis is fairly straightforward, including using this WHO-HEAM5 definitions, but there are certain limitations in this classification. That is, clinical, morphological, and viral features, they often overlap with our other entities. Okay, so what are the overlaps that can be? That is synchronous or metachronous presentation of different KSHV, HHV8 associated lesions. That means multiple type of these lesions in same patient, or morphological or clinical features of more than one entities. Okay, so it is recommended that the decision on classification and optimal therapy should be resolved in a multidisciplinary setting in challenging cases. So that what they are trying to say here is, when the only one entity is present, then it is very easy to classify them according to the criteria which are given. But unfortunately, these entities which are associated with immunodeficiency and these viral infections, many times they show a lot of clinical, morphological, and viral overlaps. So that's at that time, it is important that rather than sticking to this hard and fast defined classification, you describe them and you characterize the therapy and classification based upon whatever the setting, multidisciplinary setting you use in the classification of these disorders in those cases. So coming to the next entity, that is lymphoid proliferations and lymphomas associated with immune deficiency and dysregulation. So these are old diseases which have previously been described in the previous classification, but now they are put under this one common umbrella, and how we approach them, how we define them, and how we classify and name them, that has been properly described. So in the HEAM 4th revised edition, the immunodeficiency, there was a section on immunodeficiency associated lymphoproliferative disorders, which included separate chapters. So how these chapters were separated, they were grouped according to the disease background. So first was the lymphoproliferative disorders associated with primary immune disorders. And then second was lymphomas associated with HIV infection. Then there were 4 types of post-transplant lymphoproliferative disorders and other iatrogenic immunodeficiency associated lymphoproliferative disorders. So this was the classification of these immunodeficiency associated lymphoproliferative disorders, which was given in the 4th revised edition. Now in the 5th edition, they have renamed this category as, instead of calling it as just immunodeficiency associated, they are calling it as lymphoid proliferation and lymphomas associated with immune deficiency and dysregulation. I'll come to that term dysregulation, why they have included it. So hyperplasia arising in the immunodeficiency and dysregulation setting, that is, it is a new entity. It includes non-transplant, post-transplant lymphoproliferative disorders. And polymorphic lymphoproliferative disorders arising in immunodeficiency and dysregulation setting, it's also a new entity that includes polymorphic PTLD, other iatrogenic immunodeficiency associated LPDs. EBV positive mucocutaneous ulcers. It was previously described under the mature B-cell lymphoma, that broad family, but now it is included in this immune deficiency dysregulation disorders. And lymphomas arising in IDD, that includes monomorphic PTLDs, classical Hodgkin's lymphoma in PTLD, and lymphomas associated with HIV infection. So only this inborn errors of immunity associated lymphoid proliferation and lymphomas, this remains the same, except that this terminology is changed from primary immune disorders. They are now called as inborn errors of immunity. Okay, so what are the major changes? Why was there a need of changing these, making these changes in the classification? Because morphological features and biology of many of these disorders overlap. So it makes perfect sense to include them in one section rather than describing them as separate chapters. And then spectrum of immunodeficiencies is much broader than it was previously recognized. Like the polychemotherapy, unanticipated immune dysfunction due to immune modulatory agents, and immune senescence. New concepts are coming in the field of immunodeficiency, and that's why to incorporate all those, this classification needed a change. And these emerging concepts question the adequacy of the term immunodeficiency to describe their spectrum. Okay, so that's not always immunodeficiency term is not always adequate to cover all these, and that's why they have adopted the term immune deficiency / dysregulation as preferred term to encompass this expanding spectrum. And how it is done? They have given an overarching framework and standardized unified nomenclature. And attention is given on the shared histological and pathogenetic features in this nomenclature, and it accommodates distinct causal associations of specific lesions and specific clinical and therapeutic consequences. So, a standardized nomenclature is given in which what is the histology, what is the pathogenesis, and what is the causal association. They have included all these things in the nomenclature of these entities. So the new standardized unified nomenclature combines all relevant reporting data in the reporting system. So histological diagnosis is given according to the accepted criteria and terminology, and whether there is a presence or absence of one or more oncogenic viruses, and the clinical setting or immunodeficiency in which the condition is arising. So all these three are included in naming the disease, that nomenclature of the disease. So this is a, as I said, three-part nomenclature: histological diagnosis, viral association, and immune deficiency dysregulation setting. So histological diagnosis can be hyperplasia, then you specify which type of hyperplasia. It can be polymorphic LPD, lymphoproliferative disorder. It can be mucocutaneous ulcer. It can be lymphomas, and if it is a lymphoma, then you classify it as immunocompetent. Okay, so whatever the lymphoma is, you classify him according to that, and then you put then these two parts of the nomenclature along with that classification. So viral association, whether it is EBV positive or negative, HHV8 positive or negative. Then immune deficiency dysregulation setting, it can be inborn errors of immunity. If it is that, then you specify which type of inborn error of immunity. It can be HIV infection. Post-transplant, then you specify whether it is solid or bone marrow transplant. Then autoimmune diseases, iatrogenic or therapy related, then you specify the therapy and immune senescence. So why this is required? This three-part nomenclature, the same pathological entity, that is this, does not necessarily have the same pathogenesis and clinical behavior in different IDD settings. That's why it is important to include this causal association in the nomenclature of these disorders. Other important changes which are done in this category is primary immunodeficiency. They associated with germline mutations. They are now renamed as inborn errors of immunity. So as per the International Union of Immunological Societies. So just to keep up the name nomenclature with them, the primary immunodeficiencies are now renamed as inborn errors of immunity. So that inborn errors of immunity associated lymphoid proliferations, they can be unique to the particular this inborn error, or they can be similar to the acquired immunodeficiency settings. But here there is a lot of gray zone in this lymphoma terminology in immunodeficiency and dysregulation setting. So when we are going to classify certain lymphoid proliferation and lymphomas, it is definitely going to impact the other entities that has been described in other sections. So this one example is given in the article itself, and one I myself actually found out. I'll discuss that also. So especially the example that is given in the article is EBV plays a defining or important role in EBV positive DLBCL, classical Hodgkin's lymphoma, and lymphoid granulomatosis. So when it is EBV positive, it is occurring in elderly. So mind you, I have described this immune senescence. Notice this term immune senescence, in which they are saying it is a type of immune dysregulation. So when we are describing this as an immune dysregulation, so if DLBCL, which is EBV positive, and it is occurring in an elderly, when it classifies this, it goes directly into this. Okay, so you have DLBCL as lymphoma, it is associated with EBV, and your immune deficiency setting is immune senescence. Okay, so in these cases, how do you term it? Whether you call it EBV positive DLBCL, or you call it DLBCL EBV positive immune senescence. So that there is some ambiguity is there, and the article is not very clear on these things. And one more thing that I found out in this article is whether this primary inborn errors of immunity in which they are describing. In the previous edition, they have described this ataxia telangiectasia and Nijmegen-Burkitt syndrome as primary immunodeficiency associated with germline mutations. Okay, but in this classification, they are describing them as separately as lymphomas arising in the germline syndromes, similar to the myeloid or neoplasm associated with the germline predisposition. They have another category for the germline predisposition syndrome, and they have described these ataxia telangiectasia and NBS specifically in that entity. So the article is again unclear on this, where these entities will go, whether you will describe them under this IDD heading, or whether you describe them as the genetic predisposition syndrome. So I think we will need to read the book for these clarifications or write to the authors. But right now, this article is not very clear on this part. Okay, so just to sum up the immune deficiency dysregulation associated lymphoma, the HEAM5 revised edition, it was divided into 4 chapters, that is post-transplant lymphoproliferative disorders, lymphomas associated with HIV infections, other iatrogenic, and lymphoma proliferative disorders associated with primary immune disorders. So now, based upon the morphology, based upon the viral association, and based upon the disease association, they have been further categorized into this. Coming to the Hodgkin's lymphoma, there are not many changes in the Hodgkin's lymphoma as such. It's just that classical Hodgkin's lymphoma is clearly defined from its mimickers, and nodular lymphocyte predominant Hodgkin's lymphoma is on the way to, but it's not yet. The terminology is not changed yet. So what we know from the previous classifications about Hodgkin's lymphoma is there are two types of Hodgkin's lymphoma. One is classical and the other is nodular lymphocyte predominant Hodgkin's lymphoma. In the classical, Hodgkin's lymphoma is characterized by these Hodgkin's and Reed-Sternberg cells, which show defective B cell program. So from previous editions also, we knew this nodular lymphocyte predominant Hodgkin's lymphoma is different from this because here the neoplastic cells, they show a functional B cell program. So what is retained in this classical Hodgkin's lymphoma? What is retained from the HEAM5 revised edition? That is defining immunophenotype of the Hodgkin's and Reed-Sternberg cell, that is CD15 and 30 positive, that is retained. And the criteria for these various subtypes of this classical lymphomas, that has also been retained. Although they are saying that there is no prognostic significance with modern treatment protocols in these subclass typing, but it is retained because all these subtypes, they have different clinical features and underlying biology. That's for that sake, this subtyping is still retained, although there is no prognostic significance as such anymore for this. Like previously, the nodular sclerosis was called as a better prognosis and lymphocyte depleted was called as a poor prognostic thing, but now the prognostic significance is gone. So what is new? This was what was retained from the fourth revised edition. What is new is they have given a comprehensive section on the etiology and pathogenesis of the classical Hodgkin's lymphoma, which is based upon the new data on the crucial role of the microenvironment in modulating the disease. So classical Hodgkin's lymphoma is a disease in which the tumor cells is characterized by, it has germinal center B cell origin, and it is characterized by low number of tumor cells and surrounded in a rich microenvironment of reactive cells. So the data which is emerging, that has been a new section is given on that, and also the spectrum of pitfalls, gray zones, and mimickers of classical Hodgkin's lymphoma is described. So specifically, these nodular T cell follicular lymphomas and lymphoproliferative disorders arising in immunodeficiency and dysregulation setting, they may contain EBV positive, the cells which look like these Hodgkin's and Reed-Sternberg cells, but they are not actually those cells, and they are EBV positive. In those cases, they are saying that caution should be exercised when considering the diagnosis of classical Hodgkin's lymphoma in immunodeficiency or dysregulation setting, because sometimes it's not actually the classical Hodgkin's lymphoma. Mind you, classical Hodgkin's lymphomas occur in the immunodeficiency setting also, but many of the lymphomas which are arising in this IDD setting, they are EBV positive, showing EBV positive HRS-like cells, and in those cases, you should be very careful before calling it classical Hodgkin's lymphoma. So nodular lymphocyte predominant Hodgkin's lymphoma, it is still included in the family of Hodgkin's lymphoma in this classification, although the international consensus classification has already renamed it as nodular lymphocyte predominant B cell lymphoma, no longer the Hodgkin's lymphoma. It's now nodular lymphocyte predominant B cell lymphoma, but WHO-HEAM5 has still retained this terminology because they don't want to disturb the ongoing trials. But it is with a note that this NLPBCL, that is nodular lymphocyte predominant B cell lymphoma, it is now considered an acceptable term in preparation of future adoption of new nomenclature. So whether you write it as NLPHL or whether you write it as NLPBCL, WHO-HEAM5 is okay with that. So coming to the plasma cell neoplasms and other diseases associated with paraproteins. So there are new conditions, some new conditions are there like ASOP and TEMPI, and then structural reorganization is also there. So this plasma cell neoplasms and disorders associated with paraproteins, they are now grouped into four groups. Okay, so one is monoclonal gammopathy, other is diseases of monoclonal immunoglobulin deposition, then heavy chain diseases, and plasma cell neoplasms. So monoclonal gammopathy, the IgM MGUS and non-IgM MGUS, they remain the same, while this cold agglutinin disease and monoclonal gammopathy of renal significance, they are two new addition to this classification. And the second group is monoclonal immunoglobulin deposition diseases. These two remains, but the names are changed. So primary amyloidosis is now immunoglobulin related or AL amyloidosis, and light chain and heavy chain deposition disease is now monoclonal immunoglobulin deposition disease. Heavy chain diseases remain the same. They are just now described under the plasma cell neoplasm section. Previously, they were described separately, but now they are described under the plasma cell neoplasm section. So in the plasma cell neoplasm, plasma cell cytoma and plasma cell myeloma remain the same. While these plasma cell neoplasms with associated paraneoplastic syndromes, there are some changes. POEMS was previously also described and it remains the same. The TEMPI syndrome, it was previously provisional. Now it is a new entity. And ESOP is also included in this paraneoplastic syndrome. So there are 3 paraneoplastic syndromes now: POEMS, TEMPI, and ESOP. So what are the changes? It recognizes new entities and incorporates structural modifications. So what are the new conditions? One is MGRS, that is monoclonal gammopathy of renal significance, cold agglutinin disease, TEMPI, and ESOP syndrome. So what are the structural modifications which are done in the classification? That is sections based upon the type of paraprotein and disease burden, they are reorganized. Okay, so monoclonal gammopathy and diseases with abnormal monoclonal immunoglobulin depositions. So like previously also described, this IgM, non-IgM MGUS, CAD, MGRS, they are monoclonal gammopathies. This all I have just described with the classification itself, that heavy chain disease is now included in the plasma cell neoplasm section. So what are the new entities? So this cold agglutinin disease is characterized by autoimmune hemolytic anemias mediated by monoclonal cold agglutinin. And it has an underlying clonal B cell lymphoid proliferation, which does not fulfill a criteria for a B cell lymphoma. Then it is included. Okay, so AIHA, this cold agglutinin disease is there, but it does not fulfill the criteria for any B cell lymphoma. Then it is included here. The incidence is 4 times higher in the colder countries. In case of monoclonal gammopathy of renal significance, the plasma cell or B cell proliferation that does not meet the accepted criteria for malignancy. Okay, the malignancy criteria which are given for the plasma cell neoplasm, it does not meet that, and still they secrete a monoclonal immunoglobulin or immunoglobulin fragments, which results in the kidney injury. Okay, so in myeloma, there was a criteria for these plasma cells, like 10% plasma cells should be there, and then there should be some organ damage. So the criteria of these cell proliferation, it does not meet that, but still this kidney damage is there. In those cases, the condition will be called as MGRS. So the TEMPI syndrome is T stands for telangiectasias, E is for elevated erythropoietin and erythrocytosis, M is for monoclonal gammopathy, and P is for perinephric fluid collection and intrapulmonary shunting. So the diagnosis of this TEMPI syndrome is primarily based upon the clinical and imaging. And bone marrow is unremarkable in majority of these cases. You may find some erythroid hyperplasia and low volume of light chain restricted plasma cells in few of the cases, but in majority of the cases, bone marrow is unremarkable. So the diagnosis is mainly clinical and based upon the imaging. The second entity is ESOP syndrome, that is adenopathy, an extensive skin patch overlaying a plasmacytoma. So in these cases, the skin biopsy shows diffuse hyperplasia of dermal vessels associated with surrounding dermal mucin, and lymph nodes can show features which can mimic Castleman disease. So the risk stratification model of IgM and non-IgM MGUS is updated. Previously also these risk factor has been described, this abnormal free light chain ratio, that IgM or IgA type MGUS, all these have been called like high risk, but now they have described them as three risk factors, and based upon that, if all 3 of them are present, then it is considered high risk with a 50 to 60% risk of progression at 20 years, while when none of these risk factors is present, the risk of progression is only 5%. In case of plasma cell myeloma, the staging is of this plasma cell myeloma is adopted according to the International Myeloma Working Group, and the prognosis and risk stratification is also updated, and detailed description has been provided on the role of MRD using next-gen flow cytometry or NGS of immunoglobulin gene rearrangements and along with PET and CT. So all these investigations, their role in the describing the prognosis and risk stratification of this myeloma, and the staging is based upon the International Myeloma Working Group is adopted. So just to sum up it, The Burkitt lymphoma is now subtyped as EBV positive and EBV negative. Immunodeficiency associated lymphoproliferative disorders are now lymphoid proliferations and lymphomas associated with immunodeficiency and dysregulation. To better define these entities, primary immunodeficiencies are now involved errors of immunities. Nodular lymphocyte predominant Hodgkin's lymphoma, it still remains, but it is on the way out to become nodular lymphocyte predominant B-cell lymphoma. Plasma cell neoplasms have now new entities, that is monoclonal gammopathy of renal significance, cold agglutinin disease, Tempe syndrome, and Aesop syndrome. The risk stratification of MGUS and staging of plasma cell myeloma is updated. So that would be all for today. Thank you all for attending this.